Hi, I'm Bob Harrington.
And I'm Fatima Rodriguez. We're excited to announce Going Back to the Heart of Cardiology is moving to vibrant Miami Beach in January.
Join us January 24th through 26th, 2025 at the Fontainebleau Hotel in Miami Beach for this unique learning experience. Earn your CME credit as we discuss the assessment of patient diagnosis and learn new skills to better treat our patients.
Miami is a great place to be in January. Register today at heartofcardio.com.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio-nerds everywhere are working hard to fight this global epidemic. These are their stories.
Hey CardioNerds, we are ruminating with excitement to bring you the next installment of our Cardio-Rheumatology series. This is Rick Ferraro. I am a current imaging fellow at University of Michigan. I'm joined by the phenomenal Gerlene Kaur, co-chair for this series, and cardiology fellow at the Brigham and Women's Hospital, as well as CardioNerds Academy associate program director. Gerlene has been instrumental not only for this series, but for so many CardioNerds productions, and it's a privilege to be here with you, Gerlene.
Thank you so much, Rick. It's my pleasure to be on with you on this episode and also introduce our lead for this episode, Dr. Bree Hansen. Bree is a second-year cardiology fellow at Vanderbilt University Medical Center and is interested in women's cardiovascular disease and medical education, and is also a CardioNerds Academy faculty. Bree, welcome, and we're so excited to have you on today.
Thank you, Gerlene and Rick. I have the great privilege of introducing Dr. Brittany Weber and Dr. Michael Garshick. Dr. Brittany Weber is an assistant professor at Harvard Medical School, associate physician in prevention and cardiovascular imaging at Brigham and Women's Hospital, where she also directs the Cardio-Rheumatology Clinic. She received her MD PhD from the University of Pennsylvania, where she earned her PhD in immunology, setting the stage for her interest in cardiorheumatology. Her research focuses on systemic inflammatory conditions, harnessing advanced cardiovascular imaging and immunology. Her work has concentrated on rheumatoid arthritis, lupus, and psoriatic disease, with a focus on coronary microvascular dysfunction. Also joining us is Dr. Garshick, who is an assistant professor of medicine and dermatology at NYU Grossman School of Medicine, and is the director of the Cardio-Rheumatology program at NYU Langone Health. Dr. Garshick's research focuses on the heightened risk of cardiovascular disease in patients with immune-mediated inflammatory diseases, specifically in patients with psoriasis. Thank you both again for being here with us today.
Thank you so much, Bree, for this amazing opportunity, and to CardioNerds for this fantastic episode on inflammation. I'm very excited to be here.
Yes, thank you, Bree, Gerlene, everybody. It's really a pleasure to be here, and we're excited to talk about this topic today.
Thank you so much. And with that, we can get started with our series of patients that we'll be seeing in clinic. So today's cardio-rheumatology clinic is full of a mix of patients. And first up is Mr. Silver Scales. Mr. Silver Scales is a 46-year-old male with a history of hypertension, tobacco use, and psoriatic arthritis on methotrexate. He was referred to the CardioNerds clinic for evaluation of his cardiac risk in the setting of psoriatic arthritis and hypertension. We know that patients with rheumatologic disease have an increased prevalence of traditional risk factors, as well as having independent disease-specific risk factors. Dr. Weber, how do you address cardiometabolic risk in patients with autoimmune rheumatologic disease, like our patient Mr. Scales? And what is the interplay between traditional risk factors for cardiovascular disease, such as smoking, hypertension, hyperlipidemia, diabetes, and autoimmune rheumatologic disorders?
Thank you so much, Gerlene. This is an excellent and it's a really important question, and one that I'm really glad you asked, because one, we need to recognize and address them. So that's number one, the most important. So the fact that you asked this and that you recognize this is very, very an important point. In terms of addressing cardiometabolic risk, we can think of this from a few different angles. As you stated, we know that patients with rheumatologic diseases have an increased prevalence of the traditional standard cardiac risk factors. We also know that these standard cardiac risk factors do not truly account for this risk, and this is where we think that there's an important role for inflammation. Although there is certain nuances between a specific disease and the prevalence of a risk factor, such as, a lupus patient may be slightly different than a psoriasis, the overall notion and point for teaching is that we need to remember as practicing clinicians that these patients can have increased risk for these traditional risk factors. For instance, in psoriasis, a patient population that Dr. Garshick and I see a lot of, we know that all risk factors are more common. In fact, Dr. Garshick led an amazing review in JACC on this topic that I would highlight for everybody to look at, because he discusses the increased prevalence of the risk factors within psoriasis and also the interplay of inflammation. For instance, we can see in this study that all the risk factors are more common, but if we even just look at smoking is highly prevalent in psoriasis and exhibits a dose-response relationship with psoriasis severity. In addition to these risk factors themselves, there's an important interplay with the disease, i.e. some patients with some of these disorders, they may have diseases that required high-dose steroids. And we know that steroids can both increase your blood pressure, they can increase lipid derangements, glucose dysmetabolism, along with a host of other side effects. Another drug that sometimes I see my patients with lupus on is leflunomide, which can also be associated with hypertension. So there's a lot of nuances within our patients that we need to understand with even some of the drugs that are on. And then lastly, you mentioned hyperlipidemia, and hyperlipidemia can be a complex topic, especially for our patients with autoimmune diseases. For instance, I do a lot of my research in rheumatoid arthritis, where we and many others study the relationship between inflammation and lipids. And this can be a little nuanced, because the actual lipid value sometimes is a little challenging to associate with the exact risk. So, for instance, in RA, we know that these patients, when they're at the highest levels of inflammation, prior studies have shown they have the lower LDL. Now, if you and I'll just say that comment out loud again, that seems paradoxical, right? Lower LDL, higher inflammation. You would think lower LDL supposed to be with lower risk. And then that is this notion that you'll hear termed as this kind of those lipid paradox you hear. And this is not likely just strictly to RA. It's been most well studied in RA, but it's probably it's probably true to a lot of conditions. And so that's why when you talk about addressing cardiometabolic risk, an important thing I do in my clinic is when I'm seeing these patients, if I do assess their lipids, I need to understand what is the disease severity of which they're presenting to my clinic in, and say they're in a highly inflamed state and I check their lipid parameters that day. I always make sure I recheck that in a state of disease remission or stability, because their lipids can change based on the levels of inflammation, as well as their lipid values can change based on the biologics that they're on.
Thank you for walking us through that, Dr. Weber, in terms of how autoimmune diseases like psoriasis have increased prevalence of risk factors, but also that the standardized risk factors don't necessarily account for the totality of risk in these populations. And that paradox that you mentioned is really interesting. We've definitely been talking a lot on this series so far on our Cardio-Rheumatology series about residual risk and how lipids might not be the end-all be-all, and especially when we're talking about prevention, there's also other aspects like inflammation that we need to consider in our patients. And Dr. Garshick, your work has focused on inflammatory diseases such as psoriasis, so we would love to hear from your expertise as well about taking care of patients such as Mr. Silverscales. How does chronic inflammation in patients with autoimmune diseases like psoriasis contribute to premature atherosclerosis?
Right. So thank you for having me here today. And it's a really important question. But just first to back up and jump on what Dr. Weber was talking about, one thing that we're both actually particularly passionate on is that many of these patients with autoimmune conditions have not just a higher prevalence of the traditional risk factors, but they're also highly underrecognized. These patients, whether they have skin disease or joint disease, they see their rheumatologist or dermatologist quite frequently, and they forget to see their primary care doctor, or maybe they've never had their lipid checked or their hemoglobin A1C checked, or even their blood pressure checked. And so one very simple but important point is just making sure that these patients have their risk factors screened for, because oftentimes they're not. And I'm always shocked in my inflammatory clinic how many times I see a patient and their LDL is through the roof and they had no idea. So, but back to your question of how does inflammation contribute to atherosclerosis with a specific focus on autoimmune disease? Well, to just back up for a second, we are preventive cardiologists, so we still fundamentally believe that you need a lipid exposure. And those lipids have to create or adhere to and go through and translocate into the intima space through the endothelium. And one way that endothelium can become damaged is with chronic cytokine stimulation, such as TNF or IL-6. But once those lipids translocate, or sometimes even actively are transported through into intima space, they're recognized not being inappropriate. And monocytes turn macrophages, translocate into the intimal space. They phagocytose those lipid particles and they try to clear them. In that process, they just make things worse. And that's a process called failed inflammation resolution. The macrophages try to get that LDL out, but it can't. It's called failed atherosclerosis. And those macrophages, when they phagocytose lipid particles, they secrete more pro-inflammatory cytokines, such as IL-6, or the inflammasome ones, such as IL-1, that induces smooth muscle cell proliferation, causes more immune cells to go into the intimal space. And these atherosclerotic plaques are actually highly heterogeneous. They're filled with B cells, T cells, monocyte macrophages, natural killer cells, etc. So anything that can damage the endothelium or the immune system can potentiate atherosclerosis, such as chronic immune-mediated inflammatory diseases. And it doesn't, these are very heterogeneous, so it's hard to say which disease is involved in which process of atherosclerosis, but you can imagine it's amazing how much is translatable, where the innate immune system-driven diseases seem to increase atherosclerosis, even the adaptive ones as well. So my specific focus has been on psoriasis and how that contributes to atherosclerosis. And our lab has shown that the vascular endothelium in psoriasis patients is really highly damaged. And one way it can become damaged is via cytokines which are pathogenic in psoriasis, whether it's TNF, IL-17, even the interferons. Our lab has also focused quite a bit on the inflammasome pathway. And it turns out the inflammasome pathway is one of the highest inflammatory pathways present in psoriasis, even though it's not causal in psoriatic disease. It tends to be highly prevalent and actually damaging to the endothelium as well. Our lab is also focused on platelets. So platelets we traditionally think of are being involved in atherothrombosis or acute MI, but they're also involved in atherosclerosis, just the potentiation of atherosclerosis over time. And our lab has shown that platelets overaggregate, they're hyperactivated, they can preferentially adhere to the endothelium and damage them as well. So really it's this combination in terms of how inflammation contributes to atherosclerosis of the traditional risk factors plus systemic inflammation that leads to atherosclerosis, atherothrombosis, and eventually in systemic cardiovascular disease.
Thank you, Dr. Garshick, for walking us through the inflammatory pathway and going over the pathogenesis of lipid formation. Speaking of lipids, our next patient in the CardioNerds clinic is SLE. She's a 42-year-old female with a history of lupus and hyperlipidemia. Her total cholesterol is 210 and her HDL is 50. She's currently not on any treatment. She's interested in primary prevention of heart disease, but her ASCVD risk score is 0.8%, putting her in the low risk category, and statin therapy is not recommended. However, we know that cardiovascular disease is the leading cause of mortality in this population, and we know risk calculators tend to underestimate risk. Dr. Garshick, how can we go beyond our traditional cardiac risk factors to estimate risk in patients with rheumatic diseases?
Right. Thank you for the question. And I'll point out just the fact that this patient would walk into my clinic or Brittany's clinic is just a huge win, because while we want to see these patients who have lupus or have RA or psoriasis, unfortunately, very few young, healthy people or young people come in wanting to undergo risk stratification. It's just the fact that this patient is interested is a big win to begin with. So to start off, we know that these traditional risk scores really do underestimate cardiovascular risk in the autoimmune patient population. And one of the things I always point out when counseling patients is, she's 42. And so many of these risk scores are the 10-year risk. And I say, well, listen, you don't really care, but you do care about your 10-year risk, but you care about your 30-year risk. For she's 42, she cares about more than her 30-year risk, the lifetime or the 40 or 50-year risk. And so when you start having patients with these heightened cardiovascular risk enhancers, such as lupus or RA or psoriasis, and then these scores underestimate risk, well, you couldn't maybe not be treating them for a long time, and they could be very high. So how do we estimate risk in these patients? Well, there have been studies showing that scores like the Framingham risk score, ACC-AHA pool cohort equation, do underestimate risk. The Reynolds risk score, even though it incorporates inflammatory markers of DRP, that also can underestimate risk. And there's also a British scoring system called the SCORE2. And that was a really exciting scoring system because it actually included rheumatoid arthritis at. And that was used for a while in Britain until the risk-3 came out. And that was a scoring system that not only included RA, but also included lupus and steroid use as well. And they were actually ahead of their time. They're ahead of us in the US on the recognition of these autoimmune diseases as contributing to cardiovascular risk. But nevertheless, like most things, these scores can maybe work great on a population base, but on an individual basis, they do tend to underestimate risk quite frequently. And so a lot of times, what we do in clinic is we start relying on some of the disease-specific risk factors to help guide us in terms of what is their 10, 20, 30-year risk of having a cardiovascular event. And we also start figuring out, well, what is the downside of the intervention, of the risk stratification, and of the therapies we may offer. And so this patient has lupus. And so some of the lupus activity biomarkers I use are things like persistently positive double-stranded DNA, persistently low complement, having a persistently positive lupus anticoagulant. There's actually a study that came out of Dr. Weber's group, actually, I think very recently, she can elaborate more, where they actually took a really, really large cohort of lupus patients and tried to actually generate a new risk calculator to understand how this would compare to some of the traditional risk calculators that we frequently use, such as Framingham or the ACCHA cohort. And what they found is some of these lupus biomarkers of activity, such as low complement, lupus anticoagulant, some of the antibodies that were positive, incorporating these lupus activity biomarkers into the risk score, actually did a really nice job of predicting risk in these lupus patients. So I think in summary, going beyond the traditional risk factors, we think about disease duration in the biomarkers of disease activity, and also the treatments as well. And that's a really important point because a patient who's needed 10 years of on and off steroid treatment is probably going to be riskier. Not even so much because the steroids, which probably increases risk, but also the fact that their disease was so active, they needed such aggressive treatment for so long. And then other medications we think about when we think about going beyond the traditional risk factors in lupus would be Plaquenil. So that's a medication that can actually have cardiotoxicity. And so even though I know we're talking a lot about atherosclerotic risk, in our inflammatory clinics, when we see these autoimmune patients, we start incorporating some of the medications they may be using, how that affects risk long-term as well.
Thank you so much, Dr. Garshick. It was so important that you mentioned how these are population-based risk scores and how we really do have to take into consideration the patient who is sitting in front of us and all of their other risks that come with them, such as their chronicity of their disease, how active their disease is, and even the treatments that we're putting in for their disease as well. I think it's so important. And thank you for talking about those other risk scores that are out there. It's really awesome that we have some other risk scores that we can use for our patients. We know that our patients with rheumatic disease tend to have a higher risk for coronary vascular disease. And Dr. Weber, going off of that, we would love to hear about the risk score that your research has focused on, as well as learning more about your practice on how you estimate risk in patients with rheumatic disease and how you can incorporate additional risk factor markers as well.
Thank you so much, Bree. And Dr. Garshick was far too kind. This was a recent study that I did with my lupus research group here that was led by Dr. Constant Bader, who is somebody I work very closely with and is our lupologist and really true lupus expert, and May Choi, who's a fantastic rheumatologist doing incredible work in this space. And in that study, this was just where we adjudicated all the cases at our own institution. We were trying to identify was factors beyond the standard cardiovascular risk scores that could further identify patients at risk. And that is, it highlights the notion of the important lupus-specific factors, including things like low complement, double-strand DNA, and kidney disease. And so that is that specific study that he was so kind to mention. But I think it does get at this notion, though, that we do not have, still to this day, a specific risk calculator that we walk into clinic and we use for our RA patients. For RA, there's been a number of risk calculators, and some have performed better than the ASCVD risk calculator, but they don't perform in all cohorts. And so that is why we have this general notion that although there are some scores out there, there's not a standard score that we're all applying for each of these diseases. But your question of it, so how do we do this in clinic, right? We just said, if we're not practically using these in the clinic every day, then what do we do? And so it's a really great question. And of course, when I see a new patient in my clinic, I will still look at our standard ASCVD risk calculators. So I'll still it pops up in my Epic note. I'm sure it does for all of you, this standard ASCVD risk calculator, but I don't just use it in that same way, right? So if somebody comes up as a low risk, below 5%, I'm not going to just discount them as a patient that maybe need prevention therapies. Instead, I integrate a lot of data. So number one, we should all remember, and a really important point is that in the 2019 update, the ACC and AHA added these inflammatory diseases as risk enhancers in our guidelines. So we have to remember that these are risk enhancers. And that highlights the notion that we know that these risk scores are not going to estimate as well. They could underestimate, or, they could estimate well or over, right? We just know they're not excellent estimators. So we have them as risk enhancers. And so I use that as a risk enhancer. And then I use other data in my clinical setting to identify risk factors that may push me towards treatment. And so I also screen for the other risk enhancers in our guideline. For instance, in all my patients, when I meet them, I go back to see if they've had a lipoprotein A check. If they have, I won't necessarily check it again because it is typically quite a stable biomarker. It's much more genetically determined. And the guidelines do recommend that Lp(a) should be checked at least one time in all individuals. So I find that it's often not. So when I meet a patient, I will screen for lipoprotein A, and that is a really important biomarker in all of our patients in cardiovascular medicine. In fact, in work we've done at the Brigham in our Lp(a) research group that's led by Dr. Blankstein, we actually looked at the role of lipoprotein A with immune-mediated inflammatory disease. And this is something that I was interested in. And so we did the study, and what we observed is that lipoprotein A is at similar levels to the general population in our patients with these diseases when you take them as a whole, and that our patients with inflammatory diseases that had elevated lipoprotein A were at even higher risk. So that risk is even additive. This is some work that I presented at the ACC 2024 sessions, and hoping we will have it out. But it's an important risk factor we should be checking in our patients. And so then you ask me, so if we check a lipoprotein A and that patient level is very high, how would I act on that? And it's an important point to remember that currently we do not have lipoprotein A lowering therapies on the market. So what I do now is I know that the patient is even at higher risk. And so I use that to be more aggressive on the things I can control. And I also keep in mind ongoing clinical trials and that my patients could be eligible for. Gerline, in fact, knows these trials very well. And in fact, she's also done amazing work in our research group with Dr. Blankstein on lipoprotein A, specifically focused on the unique subset of women. And she also led a review that we all did together, as well as with Dr. Garshick, summarizing this for the trial. So something to keep in mind. So there I covered one risk enhancer. So what are other things? Well, of course, I'm going to check a high-sensitivity CRP, and I usually will check that when I'm checking their lipid panel and their standard labs. But I may use that data a little bit differently, right? Because you have to understand the disease of the patient, and since a CRP value, for instance, they may be at different levels in a patient with lupus or RA, and it all depends on what is their clinical disease activity at that time you're measuring it. So I utilize it in a little different way. And then the third thing I will incorporate into that standard ASB risk score is that I also say, is there a way, is there any imaging available, or would that be useful? So number one, in clinic, I do this at every single visit. I go back to the patient imaging review and I ask to see if they've had a chest CT. If they did, what I'll do is I'll scroll through this chest CT with the patient and I look for any coronary artery calcium, which is a burden of atherosclerosis, and we call that the calcium score. And we know that the calcium burden is a strong determinant of cardiovascular risk. In fact, the patients with severe coronary artery calcium, which is levels greater than 300, are at the highest risk. And I think this is a very important point. And we actually just did a study where we presented at the SCCT meeting where we looked at CAC, where we took CTs that were done for other reasons. So this was data that already existed in the medical records at our institution. And we looked at calcium that was detected by AI-based methods, of which there's a number of AI-based methods to do this. And we looked specifically in the diseases that I focus on, so RA, psoriasis, and lupus. And what we observed is that CAC-AI, by this method, it was highly prognostic. Even patients with a calcium score of 1 to 99, so less than 100, but above 0, had excess risk. And in fact, the risk just continued to rise with the increasing level of calcium score, but the calcium score greater than 100 group, they actually had a level of risk that was similar to secondary prevention. So if we just think about that, this is data that already exists in our medical record. And so you're asking how else I address risk in the clinic, and this is an important tool because this is often information that's there. And I think incorporating data such as these, if they're available, and if they're not, often in my clinic, I may discuss with a patient and then add a calcium score, and it's inexpensive, it's quick, it's low radiation, and it gives us a very important snapshot at that time that can then help guide our therapies.
Thank you so much, Dr. Weber. That was really incredible. And taking in context what you said about LPA and then also LDL and checking that at different time points, it really gives us a holistic picture of the patient's risk in a way that I personally didn't think of before and I'm excited to implement in my own clinic. So we do have one more patient today at the CardioNerds clinic. This is Miss Rheumatoid. Miss Rheumatoid is a 54-year-old female who has been following with the CardioNerds clinic for the past 5 years. She has a history of hyperlipidemia and rheumatoid arthritis, previously on hydroxychloroquine and methotrexate, but has had multiple RA flares requiring step up in her therapy and multiple courses of steroids in the past. Her revised ASCVD risk score is 4.1%, and her HSCRP is elevated at 2.2. In addition to checking other risk factors such as labs, lipoprotein A, ApoB, coronary artery calcium is something you already mentioned. Is there anything else that you would add to this kind of our checkup here, or have we mostly covered it?
Yeah, this is a great question, and one that really speaks near and dear to my heart, and one that, you're discussing, you're putting her risk up there, you're putting some labs up there, you're putting all the risk factors that we just talked about in our last patient. But this is really where we can start to think about imaging, where you didn't give me is any imaging data. And just kind of going along with that our patient imaging, I really do strongly believe has a fundamental role in our diagnostic prognosis and our longitudinal monitoring of these patients. Just stepping aside, apart from this question, here we're talking about atherosclerotic risk, and that's what we've been discussing today. But as Dr. Garshick alluded to earlier with Plaquenil, we should also remember that these patients can have a host of other CV manifestations, including heart failure, pericardial disease, and valvular abnormalities, of which imaging can be helpful. But to get at your question, this sounds like a typical patient in my clinic. I see a lot of patients with rheumatoid arthritis, and I can think of a couple off the top of my head that would fit this profile. So the first point is that our ASCVD risk, although low by the guideline, we cannot reassure us. And we already know that in our guidelines, RA is a risk enhancer. So this is a type of patient that I would do a few different things. First, I would actually take a very close history and I would tease out any symptoms because that would guide what I would do next. In fact, I've had many patients with RA that discount symptoms that will end up being cardiac nature because they didn't even think about it being cardiac in nature because they're blaming their kind of dull chest discomfort or their ongoing shortness of breath on their RA. And they're not even in their head thinking that this could be cardiac related. So again, similar to our second patient, if Rue was truly asymptomatic, then I would review the records and I would see if there was any data prior that I could look at to get an assessment, calcium score on a chest CT. If she was truly asymptomatic, I then may discuss with her about performing a coronary artery calcium score as a way to help us understand her risk to guide those next step therapies. In addition to driving statin therapy, a calcium score can also be a nice assessment to where we understand the burden of atherosclerosis that can then guide, would we additionally add an aspirin, such as that there's more than just mild atherosclerosis. And then we can think about other more advanced techniques. So I'll use coronary CT in my clinic frequently if there's any symptoms or if the patient's very high risk. And I would also screen in this patient population for symptoms that could be consistent with microvascular disease. In fact, it's something that you mentioned earlier. This is work that I'm very interested in. And our lab demonstrated earlier is that we looked at patients with systemic inflammatory disorders and we observed they have an increased prevalence of microvascular dysfunction. And then we looked at whether this was prognostic. So is this similarly prognostic like it is for the general population? And it was. So not only is it more prevalent, but it's similarly prognostic. And so if I'm concerned that somebody may have microvascular dysfunction, I then would perform perfusion PET imaging to assess myocardial blood flow. And so those are kind of the tools in my clinic right now. But I would actually just mention one that I think is an exciting area for us to talk on CardioNerds today. And that is what's on the horizon as novel metrics of inflammation. And these are actually tools that are approved in Europe for clinical practice, but right now they're still research tools in the US. And what I'm referring to is something called, the STAT attenuation index. And I want to just kind of briefly describe what this is so people have heard the term and also guide people who are interested into some nice studies. But we may have heard the term something called pericoronary adipose tissue, PCAP. And so what is that? So that is the fat that surrounds the coronary arteries. And what happens is that PCAT, so that adipose tissue, can change their structure in response to cytokine released when an artery is inflamed, right? So we have an inflamed artery, those the cytokines, TNF, IL-1, IL-6, that secretion changes the adipocyte morphology. And well, what does that result in? We can detect that from routine CCTA imaging using a change in attenuation index. There's now been the development of much more sophisticated algorithms that incorporate both age, gender, and risk factors along with PCAT to identify a risk score and something also called the fat attenuation index. And though it's always exciting to kind of be able to have a hot paper coming out around the time of this. But I will say that there really was a nice landmark paper that just was published in Lancet that if anybody was interested, that they should all look at. And this was something from the orphan study. And it looked at this, the role of the fat attenuation index and a coronary heart risk score in predicting risk. And the reason I think this study is so interesting is that it was a large study. They looked at 40,000 patients undergoing PCTA in 8 different UK hospitals. And they had a median follow-up of 7.7 years. And what they observed was that most cardiovascular events occurred in patients with non-obstructive coronary disease. And when they looked at the fat attenuation index, they observed that it was strongly associated with incident cardiac death and MACE. So there was increased risk in both the non-obstructive and the obstructive coronary artery disease groups, and that the patients that had the more inflamed vessels were associated with higher risk. And so what this is a really interesting potential biomarker in the future, because what this could allow is something like PHI and the AI-based algorithm that has been incorporated in this. We can then in the future be potentially adding that, because this can be added on to any standard CCT that's already been done. And so we may in the future be able to use methods such as this to go back to our clinic to identify individuals at higher risk of events who could, like with our patients with inflammatory diseases, who could benefit from more aggressive prevention. And it may identify individuals more likely to benefit from anti-inflammatory therapies. So even in our patients with inflammatory diseases, we now have an FDA approval of colchicine, although it's an unmet need to study the additional role of colchicine in inflammatory disease patients. But potentially we could have some on the horizon biomarkers that we can start to track changes to therapies.
So, Brittany, if I could add on to that real quick in terms of the imaging, because definitely in my clinic too with inflammatory conditions, I do use a lot of imaging as well. But it's like, especially when the CAC score is negative, I find myself falling back more and more in carotid ultrasounds. I can't get femoral ultrasounds like a femoral plaque, but at least in the psoriasis and the lupus patient population, there seems to be a higher prevalence of carotid athero and femoral athero as well. And so I find it to be particularly useful, especially if I'm trying to figure out a statin yes/no therapy and when the CAC score is negative, to rule out soft plaque, not just with the CCTA, but also carotid ultrasounds as well. And I'm shocked how often I find, moderate amount of plaque in the carotids. And I almost always get it covered by insurance. And no radiation. It's easily accessible across the country. So I also advocate for that. I think it's fallen out of favor, but I think in the right patient population, it can prove to be high utility.
Yeah, I couldn't agree more, Michael. It actually reminds me of a patient just recently with RA where her calcium score was 0, and she was very concerned about her risk. And we did decide to actually do a carotid ultrasound. And I think, you and I are both lucky to be able to have these tools. And I will say that one thing I found is just to make sure that the lab that is doing the carotid ultrasound, they know that you're looking for plaque, right? And so, yeah, and we found heterogeneous plaque, and that actually then I put her on prevention therapies, because otherwise she has a ton of joint pain and she was not willing to start a statin. And so that was actually able to push her to that point, and also make me convinced that she also would be benefiting from these therapies. And the calcium score 0 is a really interesting point. I forgot to mention another, there's been so many great studies in this space, but the Denmark group just published a JACC paper where they looked at autoimmune disease and patients that had coronary CTs. And what they demonstrated in that study is that even with patients with calcium scores of 0, when they compare those to patients without autoimmune diseases, they were at higher risk. I think their odds ratio was about 1.39. And so this really highlights the notion that our patient population we're discussing here today is truly a high risk patient population. And that's why we're here talking about all the ways that we can be assessing and treating risk, but also all the work we have to do in the field.
Right. Well, you brought up a good, I think, clinical pearl, which is if you're ordering a cardiac ultrasound and it's being done in the vascular laboratory to specify, you want more than just velocities. You want them to look and see if there's any plaque, because I've had to go back and look many a time and couldn't just rely on the report because I'll just get a no critical stenosis next. And so, specify exactly what you're looking for. It's a good point.
Thank you so much, both of you, for walking us through your approach and sharing your insights on carotid ultrasound as well. I think there's a lot to learn from the framework you outlined, Dr. Weber, including the importance of the history of symptoms. And sometimes we have to dig deeper with our patients to better clarify if there may be other cardiovascular symptoms. And it was great to learn from your expertise in imaging of how we can use different modalities to better ascertain risk, as well as things that are on the horizon. It's definitely a very exciting time to be in this field and to have these novel therapies that can be applied back to patients in the clinic, as well as imaging modalities. And we've been talking a lot today about psoriasis, about lupus and rheumatoid arthritis as some of the systemic inflammatory diseases, since they are the most common and each one of them is associated clearly with increased cardiovascular risk. But I want to shift gears a little bit and talk about some of the other rheumatologic diseases as well. So Dr. Garshick, can you talk to us about conditions such as systemic sclerosis, Sjogren's, and ankylosing spondylitis, or other common rheum conditions? Are patients with these conditions also at higher risk for cardiovascular disease? And how do you counsel those patients about their cardiovascular risk?
Sure. I mean, it brings up a really good point that, across a lot of these autoimmune diseases, many times they're more than just the initial manifestation or the initial description of the manifestation, whether it's in the skin or joint. And, we joke in psoriasis that it's more than skin deep. And so there was a nice paper that came out, I guess, almost 2 years ago, where they took probably any autoimmune disease they could think of. In this case, they had about 18 or so. They even included celiac, type 1 diabetics. And they lumped all these autoimmune diseases together, and they looked at a whole variety of cardiovascular outcomes. It was more than just atherosclerotic outcomes. It was valve disease, heart failure, peripheral vascular disease, etc. And they showed that even when you lump all these diseases together, on average, you have about a 50% higher risk of a cardiovascular condition when you have an autoimmune disease. And then they stratified by the individual autoimmune disease as well. And almost every disease they looked at had some sort of association with cardiovascular issues. But the study wasn't necessarily powered to look at which specific disease tied in with which specific issues. And I think that's really the problem with a lot of these autoimmune conditions, is that they're common. We talk about them a lot, but they're not that common. And so many of the diseases really are understudied. And so take, for example, ankylosing spondylitis. I mean, it's a TNF alpha-mediated condition. I think of it very similar to what I think about in terms of psoriatic arthritis. So even though it's not nearly as well studied, I tend to think of it having a higher cardiovascular risk for atherosclerotic events, but it also is associated with other cardiovascular conditions as well, such as aortic dilatation or aortic insufficiency. Similarly, Sjogren's, we traditionally think of having been associated with like a myocarditis or a pericarditis, but there's also some data that it associates with atherosclerosis as well. And what I've been particularly impressed about with my Sjogren's patients is that, we always spend a lot of time focusing on diet and exercise, but these patients, many times they really have very, very specific diets. You can't tell them, okay, I want you to eat X, Y, and Z. I want you to go on a low hypocaloric diet, stick to Mediterranean, because some of them, if they're missing a lot of teeth or they have to take a lot of the chewable supplements to get the saliva back, they're just happy to get through the day eating. So I find that condition in particular to have some unique challenges in terms of how we counsel them in terms of lifestyle modifications they can make. Then, of course, you have systemic sclerosis, which I think most of us think of it associated with pulmonary hypertension, but it's also associated with microvascular disease. It can have other myocardial issues as well. So really, I know we focus a lot on atherosclerosis and the relationship between autoimmunity and atherosclerosis, but a lot of these conditions can have cardiac manifestations spanning beyond just the vasculature. So when I see a patient, I counsel them about this. I counsel them about how the disease can impact their cardiovascular system. And that's not even before we even get to the medication. We talked about Plaquenil and then associated with that cardiotoxicity. There's a whole class of medications called JAK inhibitor are very hot right now in inflammatory bowel disease or in actually alopecia areata, and they actually have a black box warning for cardiovascular events. So I think the big picture is that the reason for these autoimmune cardiovascular clinics to exist is to understand the nuances of each condition, the treatments for those conditions, and how it impacts cardiovascular risk to adequately counsel these patients and also get them on appropriate risk modifying therapy.
Thank you, Dr. Garshick, for walking us through that and walking us through how it's not just atherosclerosis that these rheumatological conditions can cause, but also so many other cardiac manifestations. And thank you both for this incredible discussion on the intersection of inflammation and cardiovascular disease. We covered an immense amount of knowledge from the pathogenesis of atherosclerosis to the role of inflammation to risk scores, as well as alternative tests and imaging to order. Dr. Garshick, I was wondering if you could summarize for our audience the key takeaways regarding evaluating increased cardiovascular risk in patients, including psoriasis, rheumatoid arthritis, lupus, as well as the other diseases we mentioned, and assessing these patients for their cardiometabolic risk.
Right. So I think the key takeaway I would say, and it sounds incredibly simple, is the under recognition, under treatment of traditional cardiometabolic risk factors. A lack of knowledge amongst some providers and certainly the patients. And we've done our own survey studies on this as well, in terms of the association between these autoimmune disease and cardiovascular issues. It's just shocking. And so I think one key takeaway is just to screen these patients, to check their lipids, their hemoglobin A1Cs, their blood pressures. We haven't even touched on obesity and some of the new therapies out there as well. But I would say for me, that's a key takeaway. And also to have a basic understanding of the medication used to treat their conditions and how it may impact the cardiovasculature. And I would say the last takeaway, which we didn't really talk about today, which always comes up in the $1 million question that a lot of our patients ask, does treating my autoimmune disease reduce my risk of a heart issue? And I would say, despite a lot of our data and studies, epidemiologic evidence suggests maybe, but a lot of the randomized clinical trials really haven't shown that definitively yet. So that's another reason why I say target and treat the traditional risk factors, because we know that works.
Dr. Garshick and Dr. Weber, this has been such an insightful discussion. We've learned a lot about cardiovascular risk in patients with rheumatologic diseases, from the broad role of chronic inflammation to risk estimation. I think there's definitely a lot of pearls I'm taking away, and the practical tips that you shared when seeing patients in clinic. I think I can speak on behalf of Rick, Bree, and all of our listeners that this episode has been very comprehensive. There's lots to take back with us, but also for us to read further about with all of the recent studies and papers that both of you mentioned. And to end our episode today, we want to ask something that we ask all our guests on CardioNerds, and that is, what makes your heart flutter about the role of cardiovascular prevention in patients with autoimmune rheumatologic diseases? And Dr. Weber, we would love to hear your answer first.
Thank you so much, Carlene. And truly thank you to Bree and everyone at CardioNerds. This has been just so fun and really fun to get to do this with Dr. Garshick. And gosh, what makes my heart flutter is, I have to nerd out here and just say that, the fact that we are here talking about this topic today just makes me so happy. I got interested in autoimmunity back in Oklahoma, where I was born and raised at. I had the opportunity that really changed my life, where I got to do real medical research in a lab, and I studied lupus, and I tried to understand tolerance. And I remember that summer being fascinated by the fundamental problem of why your body attacks itself. And now, in 2024, we haven't solved that yet, because if we did, we wouldn't have autoimmune disease and we wouldn't be here discussing it. But what we do have is we have amazing therapy that can dramatically change the lives to the point of our patients where their diseases are in remission now. And now we're still trying to understand their diseases, but also understanding the implications of the therapies. And as a cardiologist, what makes my heart flutter the most is the role we play. And just as Dr. Garshick alluded to, I 100% agree. A rheumatologist cannot do everything in the clinic, and thus we play an important role in these cardio-rheumatology clinic models that Dr. Garshick and I are so lucky to have, because we can assess the standard cardiovascular risk factors and we can treat them with a lot of different agents, many of which we didn't even discuss today. We didn't even be able to get into GLP-1s and other risks. There's a whole thing we can do in our clinic where we work with the rheumatologist, and together, the cardiologist and the rheumatologist, as well as the entire care team model, we can really have a dramatic impact in preventing future cardiovascular disease. And lastly, I would just say that, Dr. Garshick and I are both physician scientists, and course, my heart flutters when I think about all the science that is ongoing, including all the amazing work Dr. Garshick's lab is doing and all the future landscape we have. It's just an exciting and fun time. So thank you guys again.
Thanks, and thanks for having us on. I think you're actually seeing a field grow, or we're seeing a field grow before our eyes, which is very, very exciting to me. Cardiology is becoming increasingly specialized. There's a lot of niches that are developing, whether it's cardio-oncology, and now we really have this cardio-inflammation, cardio-rheumatology field that's growing right in front of us, with a small community that's growing every few months. And I think Brittany and I both get emails saying, "Hey, we want to start a cardio room clinic. How do I give some of these, anti-inflammatory medications? I'm not used to giving them. How do I do it?" And so that to me is very, very exciting. But not just the collaborations that we get to develop across the country and across the world as this concept is being developed, and so the patients that really, they're struggling to find a specialist that understands what they're going through. I mean, we haven't even touched on pericarditis and the role that some of us are playing in that and some of the immune therapies. So what makes my heart flutter is that this field is rapidly developing and expanding and exploding. And it's a really great opportunity for people to get involved and to make a difference.
Dr. Weber, Dr. Garshick, this was really one of the incredible conversation. And I, like Gerline said so well, it encapsulates a lot of what we see in clinic, but it also tells us what's coming next and what there is left to do. And you can hear in both your voices just kind of the passion for the subject. And as a podcast listener, as a student, as a trainee, that's something that is irreplaceable and so valuable. And so I want to thank you for your time, and really excited to share this with others.
Thanks for the invitation to be here today. We appreciate it.
Absolutely. Thank you so much.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Christiana Dangas. I'm an intern in the CardioNerds Academy and a senior at Boston University. Check out the episode page for the show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.
Hey everyone, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, then keep on listening, because Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you. So just imagine leaving your office at the same time as your last patient. Now, wouldn't that be delightful? Freed AI is HIPAA compliant, secure, and takes less than 30 seconds to learn. Team, artificial intelligence cannot replace you, but it can do the administrative work that will allow you to spend more quality time with your patients and enhance your personal work-life harmony. So get back to doing what you love, helping your patients, and let Freed AI do the rest. Check out www.getfreed.ai to learn more.